Welcome to #Wednesdays Weekly, a weekly information session in collaboration with the voluntary sector and public sector partners. Today's session is One Rochdale Healthcare and Care Business Plan, Local Care Organisation Plan for System Working, and our host is Steve. Over to you, Steve.
Thanks very much, Laura, and Happy New Year to everybody. Thanks for inviting us to talk today. I'll sort of start by giving you a bit of background, really. So, first, a bit about me. So my name's Steve Taylor. I'm the Chief Officer for One Rochdale Health and Care, and I'm also the Chief Officer for the Northern Care Alliance that runs Rochdale Infirmary and the Community Health Services. And I've been the Chief Officer for the local care organisation since it really became a formal entity back in kind of 2000 and I think it was around 2018. But we were running as a shadow kind of LCO board before 2018, and the kind of history of us formally trying to work together as a system goes back to probably about 2015-16, when a number of us in Rochdale kind of got together to see if we could work together better and work together smarter. And one of the key kind of individuals in that was a lady called Sheila Downey. I don't know if people remember Sheila. She was a previous Director of Adult Social Care in Rochdale. And Sheila was absolutely committed to looking at how we work together better as a system. And at that time, one of the key drivers for us working in an integrated way was the money. There were kind of real challenges across all of the system around sustainability and our ability to live within a budget moving forward. And it was predicated on, challenging time for the NHS and local authorities in terms of their income position, and an acknowledgement that we had an ageing population that over time was going to require more and more support, and that was going to be increasingly expensive. So the view at the time was, something locally, was that if we could work together differently and integrate in a way that we haven't done to date, then that may provide better care, but also better use of our resources. And that, in some respects, still holds true today. So, give you an example. So, if you're a child that needs a wheelchair, you will probably be seen by 3 occupational therapists. So, I'll send you an occupational therapy from the community perspective. You might get an occupational therapist from local authority, and you may also get an occupational therapist from our mental health providers. And that's not necessarily a great use of resources or a great experience as a patient having 3 people from the same profession going to see you. So that wanting to use our limited resources better still holds true. But I think as time's moved on, there's lots of other reasons why we believe integrating our approach to health and care is good. But I think because we in Rochdale started that journey earlier than anybody else, really. So back in 2015, we designed a model of effectively neighbourhood care that included community health providers, it included mental health providers, it included the voluntary community sector, it included carers, included local authority, primary care, etc. Back in 2015, we have got a longer history of working together than many of our kind of colleagues in local authorities and areas around us. That I think serves us well, really, because at the beginning of last year, in February of last year, the Department of Health and Social Care came out with a new policy around integration for health and care. And when that landed, and I'll talk a bit more about that, Rochdale was probably ahead of the curve. So what our government have tried to do is put policy out there to force integration, and actually we're ahead of that in Rochdale in many ways. So in some respects, it was a challenge to us when that landed, because it was, we were further ahead, so it was almost bringing us back a bit, which was something where, you know, we were concerned about. So we've spent probably the last kind of 4 or 5 years really trying to develop our approach in Rochdale to integrated care based on a neighbourhood model, based on the principles that working together across the sector will provide a better level of care to our residents and will be more cost efficient. That's generally the rule of thumb on it. We are, as a place, Rochdale is, for those of you that live in Rochdale and know Rochdale well, the birthplace of cooperation. We invented the co-op here through our pioneers that came together in the 1800s and formed the cooperative movements. So I think there's a strong history in Rochdale of working collaboratively and cooperatively to to the greater good of the greater population of Rochdale. So I think as a town, Rochdale has got that kind of inherent DNA in it that people see the need and the benefits of cooperating and collaborating. So we were kind of pushing on open doors in many respects in wanting to work in that way. And I have to say that's not the case everywhere. I've covered not just Rochdale in my recent kind of career, but Bury, Oldham, North Manchester, some work in Salford, and it's not the same everywhere. That desire to work together and that kind of motivation to do things differently together isn't replicated in all areas. So I think there's something quite special about Rochdale and the way it views working together, and largely based on kind of a fairly long recent history of working together, but that kind of cooperative kind of culture that we have here. So if I start with the slide deck, and I think that might be easy to talk through these and try and tease out some examples of where I think we're at and I'd be keen to know where you think the voluntary and community sector will sit in what we're trying to do. So if I put up the first slide, which is, I can't put up the first slide. I think Laura's going to put the first slide. That's helpful. Let's go on to slideshow.
Is it this one?
It's the...
I can do it from here.
Usually in the bottom kind of right hand corner, isn't it? The slideshow icon. There we go. Excellent. So I said we kind of formally became a local care organisation back in around 2016, and we've spent quite a bit of time kind of doing organisational development work together, looking at how we might manage urgent care differently, looking at how we support areas of the system that have got challenges, etc. But in the middle of last year, we decided that we should really kind of write a business plan so that we'd capture everything that we were trying to do in a more proactive sense and have a plan that we could then get agreed across all partners and implement over the course of kind of 12 to 18 months, have milestones within it so we could track progress, and have something that everyone could see and sign up to and be a part of. So that was the idea, that we had to come together with something that was completely agreed as a system as the future direction of travel for Rochdale as an integrated health and care provider. And one of the drivers in that was, if you go to the next slide, was a lady called Sally McIver, who again some of you may know. So Sally was the previous Director of Adult Social Care in Rochdale and Director of Commissioning, and she now is the independent chair for the local care organisation. So between myself and Sally, we kind of head up the provider partnership. Currently, that consists of a whole range of partners. So it covers voluntary community sector, and it's Kerry Bartram that's the lead on the board for the voluntary community sector. It covers carers, so Encompass are the lead kind of for us at the board for covering carers, and it covers all the statutory kind of bodies that you'd expect to see there, like primary care, secondary care, community care, mental health care, etc. So we're still a fairly broad church of providers that come together to work together. And Sally and I were really keen, as I've said, that we agreed across us all a plan for our system. And it was drawn up really in the pandemic. So we were really conscious of the fact that, you know, we were trying to pull something together when everybody was kind of being a bit distracted by the COVID pandemic that was sweeping across us. And I think if you read some of this, it may talk about the fact that we recognised that we were in the middle of a pandemic, but at the time we were kind of getting to complete the document. We felt that we were coming out of it, but actually we're now learning we're not. We were in the middle of the next wave. I think we had 2 waves since we wrote this, so the pandemic is still very much with us. But we were committed to writing it and getting it down on paper and getting it agreed, and that's kind of what we did. So if we go to the next slide, it kind of describes three different spatial layers, if you like, in which we kind of have set the plan's context. So I mentioned earlier, we've had the integrated and innovative working together health and social care policy document that came out last February. And that was saying the NHS and social care, and the NHS in particular, was going to have to integrate more, collaborate more, and compete less. And for us in Rochdale and for us in GM, that means a real shift in the way that we work. So there are 3 kind of distinct levels to which now the system is going to operate. So one level is what we're calling the ICS level, the integrated care system level. And for us in Greater Manchester, that is Greater Manchester. So there is the development of a Greater Manchester integrated system for health and care that covers the 2.8 million people of Greater Manchester. That ICS, that GM ICS, is made up of 10 localities, of which Rochdale is one. So the next level, if you like, is each of the localities, the 10 localities that make up GM. So Bolton, Bury, Wigan, Rochdale, Tameside are each seen as one of the localities. And for us in Rochdale, that's our place. We refer to that as the Rochdale place, and that covers, you know, the kind of 230,000 residents that are in Rochdale. It's a local authority footprint. And our plan is very much focused at that level and the next level, which is the neighbourhood level. So because the evidence tells us that to really affect change in a population, you need to kind of chunk it down a bit. So trying to affect change for 250,000 people is quite a challenge. And what the evidence says is 30 to 50,000 is the kind of right number to begin to shift people's understanding, behaviour around health and healthcare. So that's what we've done. So we've currently got 6 neighbourhoods across the borough, some of which make geographical sense. So Haywood's one, Middleton's another. The Pennines is also enabled. It's kind of Littleborough and Milnrow. And then we've got Rochdale Centre and to the west, i.e. Whitworth, etc., as subdivided into 3 areas. So that's the kind of spatial levels that we're trying to work on. So and the kind of thinking behind it, and it's within in the detail of the plan, is that if we can get to a level at a neighbourhood level where we bring everybody together. So let's pick Middleton. So in Middleton, there's quite easily defined. It's got a population of just over 50,000. If you bring together in Middleton your community health workers, your primary care GPs and dentists, your voluntary sector workers, social care, mental health, etc., into one team, that's kind of the Middleton team. And that Middleton team understands what its assets are, understands in depth its population's health, its population's culture, and you give that neighbourhood, you give Middleton the autonomy and empower that team to affect change for its population, you're far more likely to create a positive impact on that population. So if I do look at Middleton and look at the data behind Middleton, you kind of see an area that's an area of deprivation on top of an area of deprivation, particularly when you're going to get into West Middleton. If you look at that compared to the rest of Rochdale, it's a real outlier in terms of the level of poverty, the level of worklessness, and in turn that then brings a real level of high health and care need. So you look at the rates of mental health issues, drug and alcohol misuse, cardiovascular disease, childhood obesity, early death due to cancer, so late cancer diagnosis, etc., etc. So you name it, it kind of is really prevalent in certain areas of Middleton. So if you've got one team that's based in Middleton and understands it to a really deep level and is working together, you're far more likely to be able to support that community in a better way than a traditional model whereby we look at the town and we all work in silos, which is how we've been established generally. So you've got primary care working in its silo, you've got mental health working in another silo somewhere else, you've got acute sector working in a different silo. So it really is about bringing different organisations together to work together for a small defined population. So that's kind of the spatial framework in which we're currently operating or we're developing. So a really detailed neighbourhood offer, a clear plan at a Rochdale level, so for our Rochdale population. And again, when you look at Rochdale, 15th most deprived local authority area in the country, and we know that poverty drives health and care need. So 15 most deprived, with areas in the top 3 most deprived areas in the country. A mortality that when we compare to the rest of GM even, which isn't great when you compare to the rest of the country, has got a poor outcome. So we if you are born and live in Rochdale, you have a shorter lifespan than you do if you live in Bury, which is shocking when you think it's only 6 miles between one town centre and the other. But then if you compare us with that kind of leafy suburbs of Surrey, there's a significant difference. You're far more likely to live with more years in ill health in Rochdale than you are in other parts of Greater Manchester. So you have a shorter life, but you also have a longer period where you're ill, etc., etc., etc. So I think that the need for us to think differently in Rochdale is really obvious when you start to look at the data. And the way that we've chosen in Rochdale to look at this is at neighbourhood level, so that we get down to street level care. So we should be able to identify in Middleton, in Rochdale, and we can do this, the streets that we're concerned about, the streets that have got the highest levels of need, and we should be doing something with that community. And I mean, conversely, we talk about Middleton, we look at central Rochdale, there's an area within Rochdale that we know, because the data's telling us, that if we do nothing, there's going to be an explosion of kind of renal failure, because we can see the prevalence of diabetes in that community. This kind of South Asian community, really high levels of diabetes, not well controlled, and if we do nothing, then they will need renal care, i.e. renal dialysis. So we can either at this point have a plan that says, let's build bigger renal dialysis units for Rochdale because we know in 10, 15 years time we're going to need them. Or we can say, let's have a plan that actually works with that local community in a different way, so that we work to support that community, to look at treatment regime compliance, diet, culture, etc., so that we don't end up needing renal dialysis for those patients, that we've averted the need for it because we've dealt with it in a different way. And you can only do that by working together differently with that community, with that local community, with the local assets in that community. And those local assets may well be, rooted in the community and voluntary sector. They might be rooted in the faith sector. It could be rooted in the business sector. And, those are kind of the areas that we now need to get into. So those are the spatial levels, and they're important for us to understand that. GM will become a really big, important influence to us as we move forward. Because GM will set, I think, standards across GM where it sees variation. So if it can see across GM that areas within GM have got, a worse rate of X or a higher rate of Y, I think what GM will be doing is saying, well, we want to, get rid of that variation. We want to standardize, at least within GM to start with, so that our GM population is getting a fair deal and equity, if you like. So I think GM will be really influential. Rochdale as a place will be really influential to everything that we do in a very different way, through the LCO, through something that's been established called a system board, which will be the kind of top of the shop decision maker for Rochdale that will help set the strategic intent for health and care in Rochdale. That'll be headed up by Steve Rumbelow, who's our council chief exec, but supported by myself, Sally McIver, and others to help set that strategic direction. And it's the LCO then that kind of works out how that's going to be delivered. And that's delivered at neighbourhood level in the main, or if it's a borough-wide offer at borough-wide level. So that's the kind of context in terms of the GM position, national position, and how we're looking at it in Rochdale in terms of spatial frameworks. Just one thing to say about the neighbourhoods. So we've got a problem in Rochdale at the minute in that the primary care networks are on one footprint. The health and care, so the health and social care network neighbourhoods, the health and social care networks on another geographical footprint. Children's are on a separate one. Townships on a different one. So we've already got this kind of myriad of different approaches to subdividing Rochdale, and they don't all match. So they all currently match, apart from children's, in Middleton and Haywood and the Pennines. So if you go to Middleton, the primary care network is on the same footprint as the integrated health and care neighbourhood, which is the same footprint as the local township, but it doesn't match the children's offer. And mental health haven't really got an approach yet. So there is work for us to do around our neighbourhood offer, because what we want ultimately is for everybody to be in the same neighbourhoods, so that we've got children's, mental health, primary care, voluntary community sector, health and social care, all working in one neighbourhood. And that's a big ask, but we're on it. That's part of our plan to get to a position where we're co-located in the same geographical footprints. Okay. You can stop me anytime, ask a question. I'll probably carry on boring you for the next hour if you don't. Let's move on to the next slide. So some of our key priorities, learning from experience, because that's going to inform our key principles, and that's important for us. I can give you a really good example of that. So one thing we've done recently is say as a system, it's really important that we learn together, not just work closely together, but that we actually learn from our experiences together. And we did a review recently of a patient that had died in Fairfield General Hospital because of a very serious illness. But when we tracked it back into community, into where he lived, there were a whole range of things that maybe as a system we could have done differently to support that particular patient that may have changed the outcome. This patient had, caring responsibilities for his mother who had dementia, etc., etc. And I just think if we can learn from those kind of experiences where perhaps he made decisions because of the pressures that were on him, because we weren't thinking about him as a in a total whole sense, we can really begin to affect people's outcomes. And I think we've set those learning experience kind of events up now every month. So we'll be running those every month, where we try and learn from where things have gone wrong, but we learn from them not in a blame way, but as a learning, as a system way. So what could we do differently? So that's key to us. Working as a population health system is really important. And as I've just mentioned, if you look at Rochdale and its population health as a whole, we've got work to do, because we are an outlier on many indicators, driven by many different things, but those things we need to tackle collectively. And when we're talking about tackling things like poverty, we can't do that alone as health and care providers. We need education, we need housing. So when we're beginning to look at our neighbourhood offer, and again, this is in the business plan, it is beginning to think about how we expand that neighbourhood to include housing, to include education, to include work, etc. So population health is important. We really want to improve the population health of our residents in Rochdale. On a similar kind of vein is the need to look at health inequalities. So we know across Rochdale there are certain pockets of our communities that don't fare as well as others. There is quite a lot of health inequalities across the borough. Some of that's driven by poverty, some of that's driven by ethnic background, some of that's driven by learning disability, etc., etc. So there's no one kind of reason why people suffer health inequalities. There's a number, but there's a real issue in Rochdale that we need to get to grips with. So that's a big piece of our work in how do we address the health inequalities in West Middleton? How do we address the health inequalities in central Rochdale, where people who have a standard offer from the NHS or from education or from housing aren't getting as good a deal as other people, and we need to work that one through. There's a real priority about addressing waiting lists, and COVID's driven that. So people were waiting before COVID for health and care interventions, and that's just been exacerbated by COVID now. So we've got pretty significant waiting lists, and a key priority for us as a local care organisation is to try and address that. Equally, early diagnosis of cancer. So again, and it links to the health inequalities comment I made just a few minutes ago. We know in Rochdale more people are diagnosed with cancer at what we call stages 3 and 4. So there's 4 stages to cancer diagnosis. It starts 1, 2, 3, 4. 1 is very early diagnosis. 4 is a very late diagnosis. And obviously, the later you get diagnosed, the less options there are for you to get treatment, because it's further advanced as an illness. So we know that we've got a population that is not seeking healthcare early enough, and we need to address that. So there's a real focus to look at how we deal with that in Rochdale. Big focus on priority on mental health. We've got significant mental health kind of prevalence across the borough, and working with our partners in mental health, and those are wide and varied. So that's Pennine Care, but it's Big Life. We provide the IAP service, it's the Gadam Centre, it's Mind, it's primary care and social care. We've got mental health offer. It's a community voluntary sector. It's Recovery Republic in Haywood. It's everybody has, I think, a contribution to make to health and wellbeing, mental health and wellbeing in our community. So it's really beginning to look at how we come up with a plan that begins to support our population with mental health. Part of our responsibility and the priority is about financial sustainability. There isn't an endless pot of money. One of the things I think is key to us in gaining financial sustainability is to shift as much public money as we can into the voluntary and community sector. So I'm really keen, and I've been looking at how we have that as a measure in the success of the LCO, really, in taking money that's currently spent in really expensive public sector services, and how we then recreate that provision, but through a voluntary and community sector offer, and therefore, getting better value for our money and a sustainability of our system, but also, a sustainability for our voluntary community sector that we can then hopefully grow and see flourish over time. And as a key priority was about research and development. The one criticism nationally and internationally about integrated care is there's not much of an evidence base behind it. So when you look globally about what research has been done on integrated care systems and the impact on populations, it's a bit scant. And when you do find stuff that's looks good, you look at the detail of the research and you'll find that it's not really comparable with the NHS and Rochdale. So there's some really good stuff in Sweden. There's a system out there, but when you look at it, it's a very small population. They're quite wealthy. They're very health focused anyway. It's not, you can't compare their population to Deep Lake or Kirkholt or Milnor, and their health system is very different. So there's a real lack of research around integrated care, and I'm keen that Rochdale provides the evidence. We've got a great integrated approach. We've got good plans. We've got a population that's untapped in terms of research, and I think there's huge opportunities here. So one of our key priorities is to develop research and development as part of our integrated offer. That will also help bring in money, because you can get money for research if your research proposals are good enough, and it gets Rochdale a profile. And I'm looking to develop Rochdale's health and care profile regionally and nationally, and we're getting there with that. Certainly regionally across GM, Rochdale is seen and thought of as a very mature, well-developed integrated health and care system. So it's about building on that, but using research to do it. Okay, next slide, please. So delivering the key principles, and this, I'm not going to go through this, but this is what I've just described really. So when you look at the top there, you've got the GM, Greater Manchester Integrated Care System. So that's that big spatial level. They're going to be looking at the whole of GM and how they support health and care across GM. And as I mentioned, maybe looking at standards, taking out variation. And then reporting directly to that is our system board, the Rochdale System Board, which, as I said earlier, is going to be chaired by Steve Rumbelow, but has got a whole range of people on there, including myself, Sal McIver, primary care representation, social care, local politicians as well. So that's a key decision-making board. So that will effectively, whether the financial flows will come into there from GM, some of the directors will come into there from GM, but we will set our intention for Rochdale at that board. And then the LCO board is the one that works out how we're going to deliver that. So the likes of us sat around going, how are we going to change? If our system board says we want to improve diagnostic, the diagnostic cancer outcomes for people in Middleton, so we want to shift them from being diagnosed at stage 4 to diagnosed at stage 2. It's for us to then look at how we're going to do that, and that might be sitting down with local community, with voluntary community sector, with primary care, to say how do we get this community to seek help earlier, or whatever that might be. And then the LCO board obviously delivers that through our neighbourhood model. So I won't spend much time on that. That's just a kind of diagram that shows how we will work as a system. We'll go to the next slide. That's great. So the LCO Priority Program. So what we did as an LCO that really forms the backbone of our business plan is look at key areas of work for us, and these are them. So we've developed what we call mandates, which is basically a plan, another word for a plan. So we've developed a group of plans that basically say, we're here now, this is where we are, but we want to get here. So how do we get from here to there in this plan? How do we transform and develop our mental health services or our neighbourhoods or our planned care to give us the system that we want, that we think will better meet the needs of patients over the next 12 to 18 months. So we've now got a whole raft of these. So we've got an urgent care mandate, that says, working as a system, working with secondary care, primary care, social care, etc. This is how we want to transform urgent care. So basically, what we want in urgent care is for less people to, access urgent care if they don't really need it. So how can we have a self-care model? How can we have people seeking appropriate pharmacy care, primary care, rather than going to A&E in Oldham? And how do we shift people in terms of accessing care from going out of the town to A&Es, like either Oldham or Bury, to be treated in Rochdale? So that's a big piece of work for us. We've got a plan around primary care. So how do we support and develop primary care as a key kind of foundation stone of our community offer? So how do we develop GP practices and all of the staff that sit around a GP practice to help support their community and what they need to do? How do we develop children's? So we know that one of the probably the most sensible ways of beginning to address population health and health inequalities is to start with our younger folk. So getting in there early with children's is really important. So we've got a plan now about how we work together to give children a better start in life. Same with mental health. How do we support our mental health and our well-being of our residents, working collectively as a system? And it goes all around. Planned care is the people that need operations or outpatients appointments, and then we've got a neighbourhoods mandate, which is what I talked about earlier. How do we get to a position where everybody's co-located in one agreed geographical footprint as the neighbourhood, and working together then? And how do we support that team to understand the needs of that neighbourhood? So how do we get the public health data and other data to that team to say this is what the needs in your population are? How do we finance those teams appropriately? How do we set up a board, a neighbourhood board, so that they feel ownership of that neighbourhood and can be accountable for it? So there's a whole load of work there. And then a big piece of work on continuing to develop the local care organisation as the way in which we do things in Rochdale, so that we stop thinking about my organisation, your organisation, somebody else's organisation. We start thinking about our system and how do we all contribute to doing the right things for our population. So a whole lot of work in a plan, continuing to develop our local care organisation as a way of doing things. So next slide, please, Laura. And this is kind of the plan on the page. So you've got each of those mandates there: mental health, children's primary care, what the programme aims are, what we think the deliverables are. So what are we going to deliver by April 2022? This plan was signed off in the middle of last year, so we're well on to a lot of this. And then what are the high level indicators that we want to track? So reduction in waiting lists, or reduction in non-elective attendance at ED, etc. And there's a whole raft of that. That's just a flavour there. There's a lot more high-level indicators that we are tracking. And then what are the enablers? So what do we need to put in place to enable all that to happen? So there's things about workforce, and a lot of focus at the minute on workforce because we're short of workforce, aren't we? So how do we develop a system workforce rather than me having a shortage of an occupational therapist and going out to recruit an occupational therapist when there's occupational therapists in local authority and in mental health that we could be working very differently with? So looking at an integrated workforce, really looking at how we recruit our workforce locally. So we're doing a whole load of work with the likes of Hopwood Hall College to say, well, if we can recruit via Hopwood, we're recruiting people from our own town. That gives them a job, that gives them income, that gives them sustainability, that takes them out of poverty, that then helps with their health and care requirements, etc. So that reinvesting into our own community rather than always going out for workforce, getting people from outside the area. So looking at how we do that. Looking at our estates as enablers, so as we develop these neighbourhoods, where do we have the centres, the hubs, the so on and so forth, and then reduce spend in that, because at the minute we've all got loads of buildings everywhere in the public sector anyway, and how do we reduce that? How do we use digital and technology? How do we support self-care through the digital advancements that are being made? How do we use technology to communicate, to engage, etc.? And then we've got comms and engagement as a separate issue. So how do we work with our population? And I guess there's a definite big role for you guys there in how do we gain insights from the people that we want to work with, and how do we engage with them? So that's the plan on the page. I think that's the last slide, but I've got probably 10 minutes left. So I'll stop at this point. I've not been monitoring the chat, my apologies. So I'll open that now, but if there's anything that people want to pick up, question, challenge, seek clarification on, happy to do what I can to answer you.